Hello, welcome to the Evidence-Based Medicine course. This is the talk on systematic reviews of therapy. Just by way of introduction, systematic reviews are becoming increasingly popular. There's a collaboration called the Cochrane Collaboration that is synonymous pretty much with systematic reviews. And you should get to know this collaboration as well as systematic reviews in general. They're increasingly popular in clinical journals, and it's really worth your while to understand how to assess them for validity and what they can actually tell you. So the goal here for systematic reviews, they're studies of studies. In other words, we're trying to find all the studies that have ever been done on a given topic and find them and put them all together in one paper. And ideally, if we can, put their data together. And this is the important point. Not all the time can you mash the data together, and we'll talk about ways where you can and can't do that. But if you can, that gets the best overall estimate of how a given therapy can work if you get all the data from all over the world done on this particular intervention. There are systematic reviews of diagnostic tests and other tests also. We'll talk mainly about therapy studies here because that's the one you'll see most often. A couple of things to remember. One, garbage in, garbage out. In other words, just if you do a systematic review and find a bunch of bad quality studies, you really ought to think twice about doing a systematic review if you're an author. If you're a reader of a systematic review and all they found are low quality studies, you should really worry about taking that information to heart. The review authors ought to tell you in the conclusions that these are bad quality studies and the conclusions are therefore tentative, but sometimes that point gets missed. Also remember, and in that case, so in that sense, validity not only of the included studies, but also of how well the overall systematic review is done is important. The other thing to remember is that absence of proof is not proof of absence. So a lot of systematic reviews, especially in the Cochrane collaboration, don't find that much high quality evidence on a given topic. And therefore, their conclusions appropriately should be, there's not enough evidence to recommend this intervention or whatever the topic is. A lot of people interpret that as the reviewer saying this intervention doesn't work. You have to read these reviews very carefully, and I encourage you to really get to ask that question of yourself. Is this absence of proof or is it proof of absence? You can never prove a negative that something doesn't work, but these reviews set up the criteria where they can know, if you find a lot of high quality studies and there doesn't seem to be a difference, and you put all the data together, there's still not a difference, you can pretty much be sure there's not a difference related to this intervention. Okay, so getting into them. Before we get into them, it's pretty common to call these systematic reviews meta-analysis. I regard that as sort of like calling a therapy study a forest plot or something like that. You're naming the study for the analysis methodology, not for the methodology of how the study is conducted. So I would emphasize calling these systematic reviews if you can. The systematic review takes into account the whole methodology of the study, the search, and all the other things that we'll talk about. Meta-analysis is just a small piece of that, and that's exemplified on the diagram here. Meta-analysis, oftentimes systematic reviews cannot meta-analyze because the studies are done in ways that are so different, or they studied outcomes that are so different, they can't put them together mathematically in one kind of analysis. In addition, you can meta-analyze any two studies that you want to. It doesn't always mean it's a good idea to do that. But meta-analysis, drug companies will often produce meta-analysis of their data on a given drug, not necessarily do a search for all existing data on a drug. So you have to be careful when you're reading meta-analyses that they're actually, sometimes they can actually be called meta-analysis and are actually systematic reviews. Sometimes meta-analyses are called meta-analysis and they're just a convenient sample of studies available to the researchers. So be careful about that. So on to validity. The 4 validity points for systematic reviews are laid out here. There needs to be a comprehensive search for evidence, explicit inclusion and exclusion criteria for studies, critical appraisal of those included studies, and there has to be an assessment for heterogeneity. So comprehensive search means the practical terms for this, the authors need to search at least a couple of electronic databases. Medline, the European version of Medline called Embase. If it's a psychiatric study, maybe PsycInfo, which is a database. HealthStar is a health services research database that you can look in. So they have to do at least a couple of those databases to satisfy this. The Cochrane collaboration often has databases as part of their library that are the results of groups looking at a given topic. So there's a musculoskeletal group, and that musculoskeletal group, as they do their reviews, will throw all the references into a musculoskeletal trial library. And so researchers can then search that library to see if they've missed anything, and that's one of that can count as one of the sources. But there also needs to be a search for unpublished data. Unpublished data is data that maybe didn't show a significant difference, or showed a negative difference, that something was harmful, and the researcher, for whatever reason, either didn't want to or couldn't get that study published. But that's important. If we have a study that shows that something didn't work, and we're trying to find all available data from that about that intervention, we need that study to show that it doesn't work in order to give a balanced view of whether the intervention works or not. So some effort to find unpublished data is important. This can be a gray literature search. Gray literature is stuff published not in the usual academic journals, so maybe on the web or in a newsletter or as an abstract at a conference or something like that. So good search for gray literature and conference abstracts and those things can help. In addition, if there's a set of researchers that are known for studying this particular thing, you'd want to write to them and say, hey, do you know of any research that you didn't publish that may be sitting in your desk drawer somewhere, and can I have access to that? And most researchers are really good about sharing this data if they can. So a good comprehensive search for evidence, including a search for unpublished data, is required for validity of these reviews. Explicit inclusion and exclusion criteria. Usually you will form a PICO question, patients, intervention, comparison, and outcome, that will detail the sort of studies that you want to look at. Sometimes it can be a little bit, you can look at studies with multiple different outcomes. So you want to look at beta blockers for asthma, for instance. But they may have studied that in different ways. They may have studied it using different outcomes, either an asthma control scale, number of hospitalizations, FEV1 rates afterwards. All these different asthma-related measures might have been measured in these different studies. Now, you'd still want to capture all that data because it talks about the intervention for beta blockers in asthma, or beta agonists in asthma. But you'd want to make sure that you were able to assess whether those outcomes were the same. And if the outcomes were all different in all the different studies, then you really want to check that and make sure that you can meta-analyze them down the road. But it's important for right now to have them in the study. You also have to have certain exclusion criteria, things that you want to make sure that you don't include in the study. And this can be almost anything. You could exclude based on validity if you wanted. If you knew there were a lot of randomized controlled trials out there, or enough to make a good statement about it, you could exclude non-randomized non-controlled trials. You could exclude cohort studies and case control studies and those type of things, and only select randomized controlled trials. If you don't know what sort of evidence is out there, you don't want to exclude those things right off the bat, though. Critical appraisal of the included studies is a very important criterion, and it's one that often doesn't show up in the reports of systematic reviews. We have to know what sort of studies we're dealing with, the validity of the studies that we're dealing with, in order to have some confidence that the statistics are correct, or that the meta-analysis and the combining of the data is actually correct. So it's important to go through each study and critically appraise it individually. So we would be looking at things that therapy articles, for instance, look at: randomization, blinding, allocation, concealment, and follow-up. You'd want to look at those things and make sure that those authors reported on those and did those things well. There are several tools to look at the critical appraisal of included studies. The Cochrane Risk of Bias tool is the most popular. The Haddad scale, JADAD, Haddad scale, is an important one that looks at allocation, concealment, randomization, and blinding, for instance. There are a bunch of different scales. The most critical part is that you identify studies that are of high value, high validity, and low validity, and note that in your review. Later on, you might want to do something called a sensitivity analysis, which we'll talk about, that excludes the low validity studies and only reports on the high validity studies. That's a perfectly reasonable thing to do. An assessment for heterogeneity is important. Heterogeneity means that the studies are too different to basically combine in any sense, either qualitatively or quantitatively. And so because studies are done all around the world in different populations, there may be studies that are just too different to be combined. This mostly comes up with the quantitative statistics in the meta-analysis itself. But really, you should be thinking about this as you go through the studies that you include. Is this study just done, maybe it meets the inclusion and exclusion criteria, but is it done so differently that you're not sure the results are comparable with the other studies in your analysis? So there should be a qualitative, a kind of a just looking at the studies included and saying, hey, that study seems like an outlier. But there can also be a quantitative evaluation of this that we'll get to in meta-analysis. So the results from a systematic review. First, descriptive statistics, just as with the randomized controlled trials. This is a different animal in systematic reviews because you're looking at a table of included studies. This should be a long sort of table of the different characteristics of each study, maybe some brief information about the number of patients they had, the intervention, the control group, a brief description of the results, and any validity concerns. That usually is makes for a nice table of included studies. And it should have all the studies that were included in the analysis. The better reviews will also have a table of excluded studies, so a brief description and why they were excluded from the study. That way the reader knows exactly what the authors were doing on their review. So that's the main descriptive statistic that's in there. Then you'll have the narrative or qualitative results. Sometimes the studies in your systematic review are so different that they can't and shouldn't be meta-analyzed. The data should not be pooled together and analyzed because the studies were done so differently. They studied different outcomes in different methods, in different time frames, whatever it is. And so basically the results of the systematic review end up being a list of so many studies show that this intervention works, other studies show that this intervention doesn't work, and the authors do their best to kind of make sense of all that, just using words, basically. But what they're really striving for, if you can find it, is a meta-analysis, the ability to combine the data from all the different studies together in a statistical method and get an assessment of the real impact of that result. Not all studies will address all the outcomes, so there's a lot of work that have to be done by authors to make the results combinable. Things like standardized mean differences and effect sizes and all these terms get thrown around as ways that authors can make the results as similar enough to be able to combine in a meta-analysis. Heterogeneity is important, and we already talked about the qualitative assessment of heterogeneity, looking carefully at the studies and see if there are studies that are just different than the rest of the included studies. Quantitative heterogeneity is seen during a meta-analysis, and I'll show you kind of an example of this. But it's a way of testing all the studies against each other to determine if the results from that study are so different that they probably shouldn't be combined. In other words, if one study is kind of an outlier in the results, you do basically an analysis, a statistical analysis, to determine if there's heterogeneity amongst that set of studies. This is done usually by a chi-square test of a certain type, and that spits out a p-value. Now the p-value in this case, normally for results, if we want a p-value less than 0.05 to show a significant difference, that's the p-value, what p-value usually means in these. For a heterogeneity assessment, we don't want there to be statistically significant heterogeneity, right? We want as much homogeneity as possible. So the p-value in this case, if it is significant, that's a bad thing. That means that there is statistically significant heterogeneity in the analysis. And what you do about that then, you might want to use sensitivity analysis, which we'll cover later, to exclude the heterogeneous studies and rerun the statistics and see if the results ultimately change. You can, or you can just acknowledge that there's heterogeneity and your conclusions are limited by that. The I-squared test is an increasingly popular version of heterogeneity analysis. Basically, you can think of the I-squared as kind of the percent of heterogeneity beyond just chance, difference between the studies. So an I-squared value of greater than 50%, you have to worry about, and a worrisome level of heterogeneity. Below 50%, you're generally okay. Obviously, the more heterogeneity by I-squared test, the worse off you are. Sensitivity analysis, again, is a way to either exclude. You can do sensitivity analyses for heterogeneous studies that pop out during the analysis. You can do sensitivity analysis for low quality studies. Once you've done your critical appraisal of the studies, you can exclude the low quality studies, rerun the statistics, and see if the better quality studies still show a difference. Remember that the general impact of low validity studies is to increase the estimate of effect. How much an intervention actually works is overestimated if you have low quality studies. So removing them might show that ultimately a drug or an intervention doesn't work. And so you have to do the sensitivity analysis to ferret that out a little bit. So this is a forest plot. Remember, we did forest plots back in randomized controlled trials. This is a systematic review forest plot. And what you see here is the list of studies or subgroups that are represented. You'll see the two groups represented. The OEP is a type of physical therapy, I believe. And you'll see the number of events out of the total weight there. The weight is the number of, is basically a weighting due to sample size. So the more subjects the study has, the more the study will weigh in the meta-analysis. This is also representative over on the actual forest plot by the width of the square, or the size of the square. Very small squares are not weighted very much. They are representative of low weighting. Larger squares representative of higher weighting. The risk ratio for each study is listed in this column with its confidence interval, and you see the risk ratio represented by the square and the confidence interval represented by the whiskers on either side. Any confidence interval that crosses 1 is not significant. So individually, each of these studies is not significant, but when combined, they produce a significant overall test statistic or summary statistic. The summary statistic here, the risk ratio 0.45 is represented by the vertical points on this triangle, and the confidence interval for the summary statistic is represented by the lateral points on the triangle. So you can see the benefit of meta-analysis here. Each of these individually non-significant studies, when that data is combined with all the caveats that we talked about before, when that data is combined, you get a statistically significant value. The heterogeneity analysis is over here. So you have the chi-square test for heterogeneity, gives you that chi-square. That's associated with a p-value of 0.84, which is not significant. And remember, that's what you want. You don't want a significant p-value for heterogeneity. The I-squared test, another way to represent heterogeneity, is over here at 0. Oops, sorry. 0, which means no significant heterogeneity. So that's a forest plot. Funnel plots are a way to look at something called publication bias. Remember that we had a big study. These are big studies looking to search for all sorts of data all around the world. And this is a way of looking at publication bias, which would mean publication bias basically says that studies that show no difference, or studies that are maybe that don't show a benefit to an intervention, are generally not published. Journals have lots of people wanting to submit their studies and show their data, but really journals have kind of a desire for studies that make a difference. And so in general, they won't publish studies that show no difference between something. And so you can see that in a funnel plot. A funnel plot plots the sample size or some estimate of or some statistic associated with sample size, like a standard error or a confidence level or something like that, something associated with sample size, against an effect size, in this case a risk ratio. And so if the overall risk ratio is 0.8 or whatever this line represents here, each individual study's point estimate is represented by these dots. What you will often see here is in the studies, and you can see it a little bit here, studies that favor control, i.e. either do not show a difference, which would be a relative risk of 1, or show a difference that favors the control group and not the intervention that you're looking at. There are fewer studies in this quadrant. And so over here in this area, there are fewer studies, and that's a funnel plot showing that there's some publication bias. There's an outlier study here, something that clearly falls out of this funnel. The funnel is meant to represent that as you get higher in sample size, and more confidence, the results of the studies tend to cluster around the true estimate of effect, this true estimate of effect here. Okay, so that's the rationale for this funnel plot. You will see sometimes you have to watch these. Sometimes the control version is on the left-hand side, so you have to kind of read these. Sometimes there will be different axes. So the effect size over here could be effect size. It could be absolute risk reduction. It could be any number, any axis over here. This can be, as I said, standard error or some sort of measure that relates to sample size directly. So you will see a number of varieties of these. So for applicability, again, these will look a lot like the therapy study slides. There are all sorts of terms for applicability, generalizability, and external validity. For internal validity of this, just to remind you that, and something to look for applicability, the review might be very valid. In other words, they did a great search, they had very explicit inclusion-exclusion criteria, they did the assessment of heterogeneity, but the studies they got, because they did the critical appraisal, the studies they got in their review might be very poor quality studies. And so even though the review was done well, it's a valid review, the included studies may not be that valid. And so you're limited in the conclusions you should draw from that study. Applicability: is the study useful for others, for other patients, and to whom can the study apply? And remember that if you're looking for all the studies in the world, these have real possibility to make a difference in what you do for a patient in terms of intervention. So the stakes are kind of high in the sense of being able to apply this evidence to other patients. So same questions: is the intervention available, both in terms of just simple availability, cost, et cetera? Does the population study match the population I care for? Same question is with randomized controlled trials. Do your patients look like the patients that the study is looked at? Are the interventions and comparisons both reasonable? Do the comparisons actually, looking at the ineffective comparator issue, are the comparators actually effective comparators? Are the interventions studied in the right doses? All the same validity questions that we had with randomized controlled trials. And finally, does the study examine patient-oriented outcomes? Studies should examine, in systematic reviews, you'll probably have a bunch of outcomes that you can look at, both disease-oriented or proxy outcomes and patient-oriented outcomes. There will usually be fewer patient-oriented outcomes studied than disease-oriented outcomes studied, and you just need to keep that in mind when you're looking over a systematic review. Okay, we're done with systematic reviews. I'll see you next time.